Hi everyone, and welcome to Unit 6 of NURS 2020 in Advanced Pathophysiology and Microbiology. Unit 6 is going to focus upon the urinary disorders. That's going to be Part 1. Part 2 will be on the fluid, electrolyte, and acid-base imbalances. In terms of the urinary disorders, we'll focus upon the UTIs, urolithiasis, so stones in the kidneys, which will be nephrolithiasis or anywhere else along the urinary tract, in which case we'll call it urolithiasis. And then we'll switch gears and look at and examine acute kidney injury, or AKI for short, and then chronic kidney disease, or CKD for short, and close off by discussing the various renal and bladder cancers. Please remember to read through the slide deck as well as all the other learning resources that are posted on the Blackboard shell. UTIs, or urinary tract infections, is the infection and inflammation anywhere along the urinary tract. It could be the upper and or lower urinary tract. The inflammation of the lower urinary tract includes the inflammation of the bladder, which we will term acute cystitis, and the urethra, which will be termed urethritis. Inflammation of the upper urinary tract includes the inflammation of the kidneys, which is termed acute pyelonephritis. So if you say a UTI, it could be really an inflammation and infection anywhere along the urinary tract. But in order to distinguish between the two, there's the upper UTI and the lower UTI. And then we get to the specific structures within the upper and lower urinary tract. So if it's inflammation of the bladder, that will be lower UTI. That is acute cystitis, which we'll focus upon, and not really urethritis. If it's inflammation and infection of the upper urinary tract, that will be really the inflammation and infection of the kidneys, which will be acute pyelonephritis. So I'm not really too fond of the term UTI because it doesn't really tell you where the infection is, so we can be more specific. But the general term, yes, is a UTI. But if you know it's the infection and inflammation of the kidney, then why not use the term acute pyelonephritis instead of just a UTI, which is non-specific and could be inflammation of the bladder as well, right? So we just don't know, but once a diagnosis has been determined, it's best to use the actual term like acute pyelonephritis. So acute pyelonephritis is very different from acute cystitis. Let's focus upon acute cystitis first. So it is the inflammation of the bladder, which is a form of a lower UTI. The risk factors for acute cystitis includes female sex, sexual activity, urinary stasis or obstruction. For example, in the case of males, the BPH causes urinary stasis, and that can increase the risk of an infection of the bladder. Any foreign body inclusion, for example, a catheter, that would be an iatrogenic form of lower UTI, as well as decreased immune system functioning, but that's true for most infection and inflammation. That could be in the case of diabetes mellitus, malignancy, or clients and patients taking immunosuppressive drugs. The clinical manifestations of acute cystitis are related to the storage symptoms, which is the urgency and frequency when the bladder mucosa is inflamed. You can imagine any urine that's going to be there for a prolonged period of time, or even for a short period of time, there's going to be urgency and frequency to void that urine. And then we have the voiding symptoms itself, which would be dysuria or painful urination, hesitancy, and post-voiding dribbling. Hematuria may or may not be present. It's usually present, and that's explainable because you have the inflammation of the mucosa of the bladder, which is going to damage those cells, and that's the transitional epithelial cells, if you remember from ANP, and that can cause hematuria. Suprapubic pain, sometimes, especially if it's a little bit more severe, and if the symptoms are really severe, then it might not just be acute cystitis. So if the severe symptoms such as fever and chills, costovertebral ankle tenderness, severe flank pain, nausea and vomiting, then it's probably not just acute cystitis. Acute cystitis has been diagnosed if you have urgency, frequency, dysuria, hesitancy, perhaps hematuria. But if fever, chills, CVA, tenderness, flank pain, nausea and vomiting is also present, then it is a dual diagnosis of both acute pyelonephritis as well as acute cystitis. In other words, both a upper and lower UTI. So please be on the lookout for that in terms of the nursing assessment. For acute pyelonephritis, the definition is an infection of the renal parenchyma, the tissue within the kidney itself. In terms of the etiology, it's usually an ascending infection from the lower UTI. or less commonly through the route of blood, hematogenous route. In terms of the causative microorganisms, it's usually E. coli or Staphylococcus aureus or some form of Enterobacter. The risk factors for acute pyelonephritis includes nephro and urolithiasis, various strictures and obstruction, and then diseases that affect the immune system functioning like diabetes mellitus, sickle cell disease, polycystic kidney disease, which damages the kidney itself. For the clinical manifestations of acute pyelonephritis, it's usually a rapid onset, so not several weeks, but several days. And then you have the clinical manifestations of a low UTI because usually it's an ascending infection, so there's acute cystitis, and then that progresses to acute pyelonephritis as the bacteria makes its way up the ureter to the kidneys. So you'll have the clinical manifestations of a low UTI, which will be urgency, frequency, and hematuria, plus dysuria if there's the acute cystitis as well. Right? But in addition to the clinical manifestations of acute cystitis, so urgency, frequency, dysuria, and hematuria, you also have more severe symptoms such as fever, malaise, chills, myalgia, potentially, almost certainly nausea and vomiting, and definitely costovertebral angle tenderness and or flank pain, along with the typical clinical manifestations of an infection, including leukocytosis. A fever would also alert you to an infection. So that's acute pyelonephritis, which is a much more severe infection compared to a simple lower UTI, such as acute cystitis. Let's switch gears and discuss urolithiasis, or stones in the urinary tract. In terms of the epidemiology, the prevalence is interestingly actually rising. 8% of the population either has or previously had an episode of urolithiasis. Firstly, the difference between urolithiasis is a stone anywhere in the urinary tract, anywhere in the tubular lumens or in the bladder. And then we use the term nephrolithiasis if it's actually a kidney stone, a stone located within the renal parenchyma. Moving back to the epidemiology, males seem to be more predisposed to developing urolithiasis compared to females, a 2-to-1 ratio in terms of males to females for urolithiasis. The peak incidence is around middle age, 30 to 50 years of age, and it does reoccur, unfortunately. 10% of folks who've had an episode of uro or nephrolithiasis will develop it again within a year, and nearly half within 5 years. The most common type of stone is made from calcium oxalate, although the other types, such as cholesterol and so forth, we're just going to focus upon the calcium stone. So anytime, as we'll see in the next part 2 of this unit, anytime there is hypercalcemia, that increases the risk of uro and nephrolithiasis because most of the urinary stones are made up of calcium. The risk factors for urolithiasis and nephrolithiasis is a low fluid intake. It increases the risk of precipitation of the stones. Excess vitamin C, kind of hard to explain that. Loop diuretics, again, because it removes fluid from the body and makes everything more concentrated, thereby increasing the risk of precipitation. Inflammatory bowel disease probably has to do with the fact that there is imbalances in calcium homeostasis, or inflammation also, we know, increases the risk of formation of these stones. Diabetes mellitus, same thing, and hyperparathyroidism, which leads to hypercalcemia, and that is definitely a risk factor for the development of urinary stones. For the clinical manifestations, they are, as you would anticipate, severe waxing and waning pain. So the pain is really severe when the stone is moving, typically down one of the tubular structures like the ureter, and then if it's not moving, after a while the pain wanes, right? So severe waxing and waning pain, which we refer to as renal colic, and that pain can radiate from the flank to the groin, the testes, or the penis in a male. Other clinical manifestations includes the writhing and persistent discomfort. The client tries to move into a position that is more comfortable, but it really isn't. And so you have that writhing movements that occurs. And when the pain gets really severe, you can get nausea and vomiting, diaphoresis, tachycardia, and tachypnea. The hematuria occurs when the movement of the stone damages the mucosal lining of the tubular structures or within the bladder itself, or for that matter within the kidney itself as well, for nephrolithiasis. Urgent intervention is required for both uro and nephrolithiasis if there's only a single kidney that is present. So if an individual has donated a kidney, for example, now that's going to be problematic, because if the urine outflow is blocked, that can lead to acute kidney injury, and that can be really, really serious, especially if there's only one kidney left. Or alternatively, if there's bilateral stones, again for the same reason, now you have affected the functioning of both kidneys, not just one kidney. Usually the urolithiasis or nephrolithiasis is unilateral, but if it is bilateral, it becomes a lot more severe. If the pain is intractable, or if there's severe vomiting that could lead to dehydration, then urgent intervention is also required, along with the fact that if there's already a pre-existing acute kidney injury, then very careful management is required to prevent the exacerbation and prevent the worsening of the acute kidney injury. Talking about acute kidney injury, or AKI, it used to be formerly known as acute renal failure, or ARF. However, please try to use AKI because the general public typically doesn't know what renal means, so we're trying to make things a little clearer, although even I will occasionally lapse into using renal more often than it's warranted. AKI is defined as the abrupt decline in renal functioning that leads to the increased concentration of nitrogenous waste byproducts that are normally excreted in the kidneys, or by the kidneys. So you have this buildup of these nitrogenous waste byproducts because the kidney functioning has declined for whatever reason. That's acute kidney injury. The clinical manifestations is a decreased GFR. So hopefully you remember GFR, or glomerular filtration rate, from A&P. That's the hallmark. That's a measurement of kidney functioning. So when GFR suddenly declines, that is acute kidney injury. That in turn leads to weight gain and edema because fluid is not being filtered out in the kidney, and even all the fluid intake, it's not excreted out. And if you're not excreting out the water, then all the nitrogenous waste byproducts are also not being excreted out, along with all the other toxins and waste byproducts, right? We're just going to focus upon the nitrogenous ones which we can measure. That in turn leads to azotemia, or the buildup of all these nitrogenous waste byproducts in blood. That in turn is measured by an increase in the blood urea and nitrogen, and an increase in the creatinine concentration. So those are the two blood tests. When you have an increased BUN and an increased creatinine, we say that the client or patient has azotemia, or the buildup of these nitrogenous waste byproducts. Creatinine is measured in order to determine what GFR is. So you can plug in the values into an equation, the value of creatinine that is, and then you get GFR. So it's really eGFR, or the estimated GFR. Lastly, the main clinical manifestations besides the decreased GFR, the weight gain and the edema and the azotemia is, yes, abnormal urine volume formation, formally defined as less than 0.5 milliliter per kilogram per hour for at least 6 hours. But that can manifest itself as anuria, or no urine production whatsoever, oliguria, or reduced urine production, or even polyuria, or increased urine production. Usually it's either anuria or oliguria, so it's oliguric acute kidney injury. Polyuria can develop, but that's a rare circumstance. We're not going to focus upon that. Usually it's anuria or oliguria. This particular flowchart shows you the classification of the various forms of AKI. So AKI, or acute kidney injury, the cause could be a pre-renal cause, it could be a renal cause or within the kidney. So now we're back to using renal, just because of the terminology is stuck, right? So pre-kidney, kidney, post-kidney just doesn't sound right. So pre-renal causes, renal causes, and post-renal causes. The pre-renal causes of AKI include hypovolemia. So if you have absolute hypovolemia, which we'll be discussing in part 2, due to hemorrhage, GI losses, skin losses, or renal losses, that leads to hypovolemia, and that means that there is not enough blood flow to the kidney, which obviously damages the kidney because of ischemia. We're not going to really focus upon this disordered autoregulation over there, but NSAID abuse and excessive use of ACE inhibitors and ARBs can lead to disordered autoregulation of GFR, and that's because it leads to disordered autoregulation of kidney blood flow. Really, it is all about GFR, but if you remember from your A&P, blood has to flow into the kidneys, and then you can get filtration at the kidneys, or glomerular filtration, which you can measure and thus get the GFR. So if you have reduced blood flow caused by NSAID abuse, or even sometimes excessive use of ACE inhibitors or ARB, and sometimes it's not excessive use, it just occurs because that's one of the adverse effects of the use of ACE inhibitors and ARBs, angiotensin converting enzyme inhibitors and angiotensin receptor blockers drugs, and that can cause reduced blood flow to the kidneys, reduced GFR, and thereby cause acute kidney injury because of the reduction in blood flow. Hypovolemia, as we said, does that as well. So those are the pre-renal causes. Essentially has to do with blood flow to the kidney. The renal causes are if you've damaged the glomerulus, for example, because of glomerular nephritis, which we'll be examining, acute glomerular nephritis. We'll look at nephritic syndrome, for example. We're not going to focus upon the vascular causes, but if you do damage the glomerulus, and there are various glomerular diseases, we're only going to examine glomerular nephritis. Or if you damage the tubules, resulting in acute tubular necrosis, we're not going to look at this acute interstitial nephritis, but either glomerular diseases such as acute glomerular nephritis or acute tubular necrosis, those are the renal causes of acute kidney injury. You're damaging the nephron, right? And we have about 1 million nephrons within the kidneys, and if you start damaging them, that's acute kidney injury. You can also have post-renal causes, but that's usually only occurs if there is a solitary kidney. So if you've donated a kidney, for example, then post-renal causes are going to be important. Otherwise, because there's the other kidney, it's usually not so common. The most common cause of acute kidney injury are pre-renal and renal. We're not really going to focus upon post-renal. But post-renal causes could be urolithiasis, for example. So if you block the flow of urine, especially if it's a solitary kidney, that can cause backing up of urine into the kidneys, causing hydronephrosis, and that's going to damage the kidneys, resulting in acute kidney injury. So those are the various causes of acute kidney injury: pre-renal, renal, post-renal. Here's a much more detailed flowchart illustrating the pre-renal, renal, and post-renal causes of acute kidney injury. So for pre-renal, just to remind you, it could be due to an absolute decrease in the effective blood volume, for example, hemorrhage, skin losses, GI losses, diuretic use, and burns and peritonitis. That would be third spacing over there. It could even be due to a relative decrease in the effective blood volume due to heart failure, especially right-sided heart failure, sepsis, anaphylaxis, liver cirrhosis. For the intrinsic renal or the intrarenal causes, we're not going to focus upon the vascular causes. Acute glomerular nephritis, so if you damage the glomerulus, that's going to cause damage to the nephrons, resulting in acute kidney injury, acute tubular necrosis as well. Most of the causes of acute glomerular nephritis are autoimmune in nature, except this post-infectious glomerular nephritis, which is triggered by a previous infection, but that's also autoimmune related. For acute tubular necrosis, what can damage the tubules? Where it could be ischemic causes, if that's kind of related to the pre-renal. So pre-renal decrease in the effective circulating blood volume can cause ischemia, and that can cause acute tubular necrosis. So it might be starting off with a pre-renal cause, but then it goes to a intrarenal or intrinsic renal cause. In other words, acute tubular necrosis. But more commonly, acute tubular necrosis is caused by nephrotoxic drugs. So there are various nephrotoxins, including these various antibiotics, the aminoglycosides, amphotericin B, which is used as an antifungal agent, for example, various contrast agents. Anytime you take a contrast CT or MRI scan, they will always ask you, do you have any history of kidney injury? Because that can only aggravate the acute kidney injury. Various chemotherapeutic drugs such as cisplatin and various other toxins such as ethylene glycol. So all those drugs and toxins can damage the tubules, leading to acute tubular necrosis, and that's the intrinsic renal cause of acute kidney injury as well. There are also endogenous toxins, so these are toxins within your body. So for example, if there is rhabdomyolysis, so damage and breakdown of the muscles, that can lead to myoglobin being released into the bloodstream, and that can damage the tubules of the nephron, resulting in acute tubular necrosis. If you have massive hemolysis, the hemoglobin can also do the same thing as well. And lastly, sepsis can also damage the tubules, leading to ATN, or acute tubular necrosis. Post-renal is all about obstruction of the collecting system. So anytime you have a urolithiasis, especially, again, it's most prevalent if there's a solitary kidney over there, or if you obstruct the flow of urine from the bladder as well. So the actual definition of acute kidney injury, or AKI, is the abrupt and sustained decline in the glomerular filtration rate, of GFR, caused by an ischemic insult. That could be the pre-renal cause, or a nephrotoxic insult resulting in ATN, which is an intrarenal cause. GFR has to be reduced in the case of acute kidney injury to prevent life-threatening loss of fluids and electrolytes from the non-functioning tubules, like in ATN, or acute tubular necrosis. So what's the etiology? We've actually already covered that in the previous flowcharts that we saw. So hypotension is a pre-renal cause of acute kidney injury. Sepsis is also another cause, mostly pre-renal, but could also result in ATN or intrarenal. Nephrotoxic drugs, we saw that's definitely can lead to ATN, or acute tubular necrosis, which is an intrarenal cause of AKI. Rhabdomyolysis also damages the tubules because of the release of the myoglobin, resulting in ATN, or acute tubular necrosis, and that's a form of AKI, or acute kidney injury. Lots of acronym. Please make sure you know your acronyms. As we mentioned, pre-renal AKI, so if you have hypertension, that can ultimately progress to acute tubular necrosis, which is an intrarenal form of acute kidney injury. So it doesn't have to just be pre-renal or intrarenal or post-renal. Usually pre-renal can then progress to intrarenal causes of AKI. So pre-renal AKI can progress to ATN, which is an intrarenal cause of AKI. More importantly, what are the clinical manifestations of AKI? As we mentioned previously, it's an abrupt rise in creatinine. When creatinine rises significantly, it tells you that GFR has declined. That's the definition. So you measure creatinine in order to determine what the GFR is. And when GFR declines, that in turn causes the buildup of all these nitrogenous waste byproducts. You measure BUN, blood urea nitrogen. There are three phases for acute kidney injury. Initially, when the kidney is damaged, let's say it's acute tubular necrosis, an intrarenal cause by rhabdomyolysis or some nephrotoxic drug, that will lead initially to the oliguric phase, because GFR will suddenly decline, because you want to prevent the life-threatening loss of all these fluids and electrolytes, because the tubules are no longer going to be able to reabsorb all the fluid that is filtered at the glomerulus. So it's initially the oliguric phase, whereby you have decreased urine output, but because you're not excreting out enough fluid, the nitrogenous waste byproducts build up, resulting in azotemia, uremia as well. Azotemia is all the buildup of all these nitrogenous waste byproducts. Uremia is a buildup of really the urea-based nitrogenous waste byproduct. It's better to just use the term azotemia rather than uremia, although we'll see it's called uremic syndrome. What happens when all these nitrogenous waste byproducts build up in the body? So the oliguric phase usually lasts about 2 weeks. And then, as the tubules slowly recover their function, it can lead to the diuretic phase, whereby instead of a reduced urine output, now you have vastly increased urine output. It can be more than 500 mils per day, and that in turn now leads to a rebalancing of the various electrolytes in the body. So it progresses from the oliguric phase to the diuretic phase, because during the oliguric phase you have a lot of water and salt and various other solutes that have built up into the body, and now you got to get rid of, so to speak, all of that, right, in order to ultimately go back to homeostasis. So from the oliguric phase it progresses to the diuretic phase, and then you go into the recovery phase, whereby everything goes sort of back to normal. So the tubular function recovers and urine output goes back to whatever the normal levels are for that individual. So here's another flowchart that illustrates acute tubular necrosis, if it wasn't already clear from the previous two flowcharts. The main causes of acute tubular necrosis, or ATN, are the various toxins. If it's a toxin from outside of the body, it's like the antibiotics, like the aminoglycosides, amphotericin B, various chemotherapy drugs like cisplatin, contrast media, heavy metals like mercury, and ethylene glycols. But don't forget the endogenous toxins. These are toxins that are present within the body, such as all the bacterial toxins that are released during an infection, sepsis. These are called the endotoxins, especially the gram-negative bacteria. In the case of rhabdomyolysis, it releases myoglobin. That's very toxic to the tubules. Hemoglobin in the case of hemolysis. So if you have that's the reason why blood transfusions need to be carefully matched. If they're not matched, hemolysis is going to occur, and that can lead to acute tubular necrosis, which is a form of AKI. Tumor lysis syndrome and various neoplasms, such as especially multiple myeloma, can cause a release of various endotoxins, causing acute tubular necrosis. But ATN can also be caused by ischemia. This is really a pre-renal cause, so that's why we said that pre-renal causes of an absolute decrease in circulating blood volume can then lead to ATN. So yes, if you have reduced blood volume, now there's reduced blood flowing to the peritubular capillaries, that can lead to ATN. So I'll leave you to go through this, but hemorrhage, skin losses, GI losses, or even a decrease in the effective circulating blood volume, you might not have actually lost that blood, but you have that so-called third spacing. This we'll discuss in more detail in part 2. Let's now discuss the glomerular diseases. This could be an intrarenal cause of acute kidney injury. We've discussed the causes of ATN, and now we're going more proximal in the nephron, going back to the glomerulus to see what are the various diseases and disorders that can affect the glomerulus, because if you damage the glomerulus, you can cause acute kidney injury. So glomerular diseases have diverse clinical manifestations, including hematuria. So if you damage the glomerulus, now actual blood cells, red blood cells, can get filtered through, and that can cause hematuria. You can damage the basement membrane, resulting in proteinuria, hypertension because of the damage to the juxtaglomerular apparatus, and that's all involves the renin-angiotensin-aldosterone system. There's no time to do this over here. Hopefully you remember it from your ANP. Edema is also another common clinical manifestation of most glomerular diseases, along with, yes, decreased GFR. There are 4 syndromes that are associated with these various glomerular diseases. We're not going to go through the individual glomerular diseases. We're just going to focus upon these 4 syndromes. One would be the asymptomatic urine abnormalities. So some individuals just have hematuria, such as myself, and that's probably because of the basement membrane is not quite as thick. So I have a thin basement membrane. It's actually self-diagnosed, but in either case, that can cause hematuria and perhaps proteinuria as well. So, but there are no other symptoms, so we're not going to focus upon that. We will focus upon the nephritic syndrome, and especially acute glomerular nephritis. Acute glomerular nephritis is a form of a nephritic syndrome. There are other types of nephritic, other causes of nephritic syndrome, but we'll only focus upon acute glomerular nephritis. We'll also discuss nephrotic syndrome, and then lastly, we will also, towards the end of this discussion, we will examine end-stage renal disease, or ESRD, which is the end stages of chronic kidney disease as well. So what is the nephrotic syndrome first, and then we'll do nephritic syndrome. The clinical manifestations of the nephrotic syndrome is heavy proteinuria. That's a hallmark clinical manifestation. So here you have protein being filtered through the glomerulus. Why is not important, but it just has occurred. Usually it's an autoimmune related syndrome, and hence the treatment is immunosuppressive drugs. But heavy proteinuria, more than 3.5 grams of urine being filtered at the glomerulus, is the hallmark clinical manifestation over there. So what's the main protein in blood? Albumin. And thus, when you filter out all the albumin and don't reabsorb it, which it cannot be reabsorbed, hypoalbuminemia will result. Hypoalbuminemia now causes edema. Why? Because we have altered the osmotic concentration of blood. Remember, from ANP, capillary exchange depends upon the hydrostatic pressure that pushes the fluid out of the capillaries, and the osmotic pressure, which is all the proteins in blood, that pulls the fluid back in. Usually hydrostatic pressure is a little bit greater than osmotic pressure across the entire, from the arterial end to the venous end of the capillary bed, and consequently you have a little bit more fluid exiting the capillary than entering it back. And that's the reason why you need the lymphatic system to drain all that excess fluid. But now if you have hypoalbuminemia caused by the heavy proteinuria and nephrotic syndrome, less fluid will be pulled back into the capillaries, more fluid will be left out, resulting in edema. The body will try to compensate for the reduced albumin content of blood, the hypoalbuminemia, by getting the liver to produce more albumin. That's where albumin is produced. But the problem is, in the liver, albumin is produced as a lipoprotein. And so when you produce these lipoproteins in order to compensate for the loss of albumin, in order to produce more albumin, yes, you will produce more albumin, but at the same time you'll produce more lipids when the lipoproteins are cleaved. So when the lipoproteins are cleaved, you'll get albumin, but you'll also get more lipids. So hyperlipidemia will also occur, and that is the elevated HDL cholesterol levels that are measured. Right? That's hyperlipidemia. So much lipid can be produced because you want to increase the production of albumin, so you produce a lot of lipoproteins, resulting in, when the lipoproteins are cleaved, hyperlipidemia. But now so much lipid is produced that the lipids can even spill over into urine, causing lipiduria. And hence the client may report frothy urine because lipid, oil, and water don't mix. Lastly, because of the increased filtration at the kidneys, in the glomerulus, more specifically in the nephron, so proteins are filtered like albumin, but it's not just protein that is present, it's not just, albumin that is present in blood. There are various other proteins, including all these anticoagulants, natural anticoagulants, such as antithrombin 3, protein C, protein S. Those are all lost at the glomerulus as well. They are filtered at the glomerulus and thereby lost in urine. Consequently, in the nephrotic syndrome, it can result in a hypercoagulable state. Individuals with nephrotic syndrome may be more prone to thrombosis. That's what we mean by a hypercoagulable state. Why? Because of the loss of the natural anticoagulants at the glomerulus. They are all proteins, remember. So here's it in schematic form over here. So you have some glomerular damage. Why is not important, usually autoimmune related. That leads to increased filtration of proteins, especially albumin, causing proteinuria. That in turn causes hypoproteinemia, hypoalbuminemia, really. That decreases plasma oncotic pressure, resulting in edema. The compensatory response is the increased synthesis of the lipoproteins by the liver, but then that's cleaved, that causes hyperlipidemia. Sorry, that's my kids coming back from home. So I'm going to end it here to try to edit that out. But please make sure that you go through this flowchart to try to explain the hallmark clinical manifestations of the nephrotic syndrome, mainly heavy proteinuria, thereby resulting in hypoalbuminemia, edema, hyperlipidemia, lipiduria, causing frothy urine, and not mentioned over here is the hypercoagulable state due to the loss of the natural anticoagulants in blood. Before we move on to the nephritic syndrome, I just wanted to use this particular diagram to illustrate the difference between the nephritic and the nephrotic syndromes. It's actually a spectrum. So on one hand, we have the nephrotic syndrome, which has to do with the abnormal glomerular permeability. So the glomerular membrane, or filtration membrane, if you remember from A&P, consists of the endothelium, the basement membrane, and on the other side, the food processes of the podocytes. So in the case of the nephrotic syndrome, the main issue is that it has altered the glomerular membrane, filtration membrane. So now you have abnormal glomerular permeability. Why that's the case, it's usually autoimmune in nature. So if you look over here, it's all these things called minimal change disease, membranous glomerulopathy, and so forth. So it's really not important in terms of the etiology. It's usually autoimmune in nature. The hallmark clinical feature of the nephrotic syndrome, if you remember, is heavy proteinuria. And then on the other side of the spectrum is the nephritic syndrome, which has to do with the actual inflammation of the glomeruli. What causes the nephritic syndrome is also autoimmune in nature. So you can see here diffuse proliferative glomerulonephritis, concentric glomerulonephritis. All of these are caused by autoimmune conditions. One particular example, as we will see in terms of the etiology of the nephritic syndrome, is what we refer to as post-beta streptococcal glomerulonephritis. We'll discuss the immune system disorders in a later unit, but, well, actually we did it in the previous unit, but it has to do with the fact that after streptococcal infection, the antigen-antibody complexes, it's a type 3 hypersensitivity reaction, develops. The antigen-antibody complexes get deposited in the glomerulus, thereby triggering inflammation, thereby causing the nephritic syndrome. So the typical scenario is that it's a young individual, usually a not preschooler, but usually around usually around 10 years of age or so, and then they have a severe sore throat that is a streptococcal infection. It causes strep throat, and then a few weeks after that, they develop this nephritic syndrome, which we refer to as post-streptococcal glomerulonephritis or post-infectious glomerulonephritis. The point being is that the nephrotic syndromes is a spectrum. On one side you have the nephrotic syndrome, on the other side you have a nephritic syndrome, but it's really a spectrum, and some individuals can have features of both the nephrotic and the nephritic syndrome. So if you compare the clinical manifestations of the nephrotic versus the nephritic syndrome, and we'll focus more on the nephritic syndrome on the next slide, as mentioned, the key difference is the proteinuria. In the nephrotic syndrome, it's very heavy. In the nephritic syndrome, it's less so. It doesn't mean that there is no proteinuria in the nephritic syndrome, because after all, you're still damaging the glomerulus. In terms of the nephrotic syndrome, we went through the clinical manifestation. Is there going to be edema? Yes, in both the nephrotic and nephritic syndrome. Oliguria, more so in the nephritic syndrome than in the nephrotic syndrome. So the nephritic syndrome you think of as really severe inflammation. So yes, the entire nephron and the glomerulus is going to be affected. So oliguria is going to be present. Perhaps the tubules have been damaged as well. Who knows? For the nephritic syndrome, the hematuria is far more prevalent compared to the nephrotic syndrome. Here it says no for hematuria, maybe a little bit, but hematuria is far more prevalent in the nephritic syndrome. So the key difference is in the proteinuria is far more prevalent in the nephrotic syndrome. Hematuria is far more prevalent in the nephritic syndrome. Other features we saw for the nephrotic syndrome is hypoalbuminemia due to the increased permeability at the glomerulus. Albumin is filtered, that's the proteinuria, leading to increased production of the albumin as a lipoprotein in the liver. When that is cleaved, it leads to hyperlipidemia. Other features, as we'll illustrate on the next slide more so, of the nephritic syndrome, besides the hematuria, severe hematuria, and some proteinuria, although not as heavy as in the nephrotic syndrome, is the presence of these red blood cell casts. This is what a red blood cell cast looks like under urine microscopic analysis over there. In terms of the blood reports, you will see an elevated burn-creatinine ratio that tells you that the entire functioning of the kidney has been affected. When you have elevated creatinine ratios, it tells you that the GFR is decreasing, and when the GFR decreases, the blood urea nitrogen concentrations should increase, because all the toxic nitrogenous waste byproducts are building up in the plasma and blood. In addition, hypertension is a common feature due to, as it's explained, the dysregulation of the renin-angiotensin-aldosterone system, also because of the presence of the oliguria. So a lot of water is retained in the body, increased blood volume, leading to hypertension. Here are the clinical manifestations in summary of the nephritic syndrome: proteinuria, although not as massive as in the nephrotic syndrome; hematuria, far more severe compared to the nephrotic syndrome; azotemia, which is really the increased creatinine and BUN levels; red blood cell casts in the urine, we saw that on the previous slide; hypertension due to salt and water retention; and peripheral edema. Usually the edema is not as severe as in nephrotic syndrome, although it could be. And the key, besides the peripheral edema, you also have periorbital edema, again usually more severe in the nephrotic syndrome compared to the nephritic syndrome. Let's move on now to discuss chronic kidney disease, or CKD for short. Chronic kidney disease is the progressive abnormal functioning of the kidneys for greater than 3 months with either the GFR of less than 60 mL per minute or other markers of kidney damage, which could include hematuria, proteinuria, or other anatomical abnormalities. So essentially, chronic kidney disease is based mainly upon GFR measurements. And how do we measure the eGFR or estimated GFR? By measuring creatinine levels. As creatinine levels creep up, GFR levels decline, and that, when it reaches below 60 mL per minute, indicates chronic kidney disease, especially if it's more than 3 months in a year. So what are the clinical manifestations of chronic kidney disease? As GFR declines, you're going to have, and that's measured, remember, by an elevated creatinine levels, but as GFR levels decline, the blood urea nitrogen concentration is going to increase. So you're going to have abnormal blood markers, elevated creatinine and bun levels. As the GFR declines, more and more water and salt is going to be retained, leading to volume overload, hypovolemia. We'll discuss fluid electrolyte and acid-base imbalances in part 2 of unit 6. So when there is now volume overload, hypovolemia, hypertension and edema is going to be present as well. In addition, if you remember from your A&P, the kidneys produce erythropoietin, EPO for short, which regulates the production of the red blood cells. When the kidneys are damaged, that's what chronic kidney disease is, less EPO is going to be produced, resulting in anemia. The kidneys are obviously also involved in regulation of electrolytes and acid-base balance, which we'll be discussing in part 2. Consequently, in chronic kidney disease, there are going to be various electrolyte and acid-base imbalances. For example, metabolic acidosis develops as the kidneys are no longer able to properly excrete all the metabolic acids, such as sulfuric acid, hydrochloric acid, etc., that the body produces via day-to-day metabolism. Lastly, left long enough, chronic kidney disease will result in the so-called uremic syndrome. Uremia is simply the buildup of all these toxic metabolic byproducts in the body, as well as the development of various endocrine disorders. That's a little bit harder to explain, but for example, osteoporosis and hyperparathyroidism is far more prevalent in clients and patients with chronic kidney disease. What are the etiologies of chronic kidney disease? Nearly half, or 43% to be exact, of all cases of chronic kidney disease is caused by diabetes. In other words, poorly controlled blood glucose levels will likely eventually lead to chronic kidney disease. Another quarter of the cases of chronic kidney disease is caused by poorly controlled hypertension, and the remaining 16% or so is caused by various forms of glomerulonephritis, pyelonephritis, or inflammation of the kidneys, as we saw previously, as well as other congenital, hereditary, and cystic changes like polycystic kidney disease of the kidneys. But remember, nearly 2/3, in fact more than 2/3, nearly 80% of all cases of chronic kidney disease is caused by diabetes as well as hypertension. Here are the various stages of chronic kidney disease. Stage 1 is when GFR is actually normal, so this is just slightly declined. Maybe GFR is more or less normal, which is greater than 90 mL per minute, but there are other indications, other serum markers, or if creatinine has been rising a little bit, other indications of chronic kidney disease, the clinical manifestations, which we'll look at. Stage 2, you have a mild decrease. You can see 60 to 89 mL per minute. And this per 1.73 meters squared is per total body surface areas. But the problem is this is based upon a male, approximately 6 feet, who weighs 72 kilograms. So the majority of people are not in that category. But in either case, stage 3 is GFR declines even further. Stage 4, you have a severe decrease in GFR of 15 to 29. And stage 5, which is also referred to as end-stage renal disease, or ESDR, you can see the GFR is less than 15. In other words, dialysis is required at this stage, even at stage 4. ERDS represents an irreversible decline in kidney functioning that will eventually require dialysis or a kidney transplant. What are the risk factors for end-stage renal disease? Proteinuria, which is more than a risk factor, is actually an indication, an early clinical manifestation of the damage that's being done to the glomerular filtration membrane and overall to the nephron in the kidney itself. But the main risk factors are diabetes mellitus and hypertension. We saw those are by far and away the two most common causes of chronic kidney disease. As you age, the GFR declines, so age is a risk factor, but it's non-modifiable. Hypertension and diabetes mellitus are modifiable risk factors. Tobacco use is modifiable. Obesity as well. Family history is a non-modifiable risk factors. So what are the clinical manifestations of end-stage renal disease? It is pretty similar to all the other clinical manifestations that we saw in terms of the glomerular diseases as well, but you will have volume overload as the GFR declines. So how do you measure hypovolemia? Weight gain. Hypertension is a result of the increased retention of salt and especially water. And then you can have peripheral and/or pulmonary edema as well. In addition, electrolyte abnormalities are going to be very common. We'll discuss it in part 2. But the kidneys are responsible for excreting most of our potassium intake, so hyperkalemia is going to be prevalent. Hyponatremia, because of the dilutional nature, usually when there's hypovolemia, you've diluted down everything, so hyponatremia develops. We will discuss that shortly, and hypocalcemia as well. But the biggest issue with end-stage renal disease that requires or necessitates dialysis is this uremic syndrome. If the kidneys are not functioning properly, then you have the buildup of all these various toxic metabolic byproducts, including all the nitrogenous waste byproducts, and that results in the uremic syndrome that can affect the functioning of any and all the organ systems in the body. Right, so we'll discuss the manifestations of the uremic syndromes when we look at a figure shortly, but it is all the clinical manifestations which can be very varied because it can affect literally any organ system in the body. In addition, the uremic syndrome can also be caused by, or really besides the buildup of all these nitrogenous and other toxins, it can also be caused by various hormonal deficiencies and imbalances. So here's a uremic syndrome. It can affect any and all organ systems in the body. I'm not going to go through this, there's just way too many, but it can affect the functioning of the brain, resulting in lethargy, anorexia, seizures, all the way to coma, the musculoskeletal system, hematological manifestations, anemia we can explain because the kidney produces EPO, bleeding disorders, perhaps because of the loss of the various coagulation factors in the body as the kidneys and the glomerulus becomes more permeable, gastrointestinal issues, cardiovascular issues including various arrhythmias due to the buildup of toxins and all these metabolic byproducts, pulmonary manifestations, certainly acid-base imbalances, which will be discussed in part 2, and especially this metabolic acidosis and hyperkalemia. Hyperkalemia in turn can lead to various lethal arrhythmias. Endocrine and other metabolic disturbances. These ones are a little bit harder to explain. Hyperlipidemia could be explained by the nephrotic syndrome. The buildup of urea and all these other nitrogenous waste byproducts typically causes pruritus. That's one of the very common features of the uremic syndrome. So pruritus, or whole body itching, and yellow pigmentation. This is similar to the buildup of bilirubin, but these nitrogenous waste byproducts, including bilirubin, have all of them have this yellow pigmentation, so the skin becomes yellow, especially the sclera. So usually we associate jaundice or icterus with liver disorders, but the uremic syndrome can also lead to this yellow pigmentation of the skin. In other words, the uremic syndrome can affect any, and eventually it will affect all the organ systems in the body. We're going to switch gears now and discuss very briefly the cancers that affect the kidneys, and the most common one being renal cell carcinoma, at least in adults, or RCC for short. RCC represents 85% of all primary malignant tumors in the kidneys. In terms of the epidemiology, you can see males are slightly more affected compared to females, 1.5 to 1 ratio. Like most cancers, the peak incidence occurs later in age, usually 50 to 60 years of age. The risk factors are pretty much the same risk factors for most of the other cancers, maybe with the exception of this hypertension, but smoking, obesity are well-known risk factors for most malignancies, and then for RCC we can add hypertension. The clinical manifestations, unfortunately, for RCC, it's usually asymptomatic until the very late stages. The indicators for poor prognosis include weight loss, weakness, anemia, and bone pain, which typically indicates that the cancer has metastasized. If there are clinical manifestation, it is referred to as a classic triad, where you have gross hematuria, flank pain, and a palpable mass. These two are because of the growing tumor in the kidneys that impinge upon the nerves in the area, causing flank pain, and sometimes it grows to a significant size that you can actually palpate the mass itself, and gross hematuria being the other one. So if anytime there's hematuria in an older adult, it might be a UTI, but it also might be renal cell carcinoma, so it needs to be investigated further. As mentioned, most cases of renal cell carcinoma are asymptomatic until the late stages, and hence when it's diagnosed, metastasis is usually already seen in up to 1/3 of new cases, because the tumor has been growing for quite a while already and metastasis has occurred. So common sites of metastasis are to the brain, to the bone, the liver, the lungs. Those would be the common sites. So that's RCC in adults. The other one, in terms of the urinary system, would be a bladder carcinoma. It's the second most common urological malignancy. In terms of the epidemiology, it does affect males far more commonly compared to females, a 3-to-1 ratio. The mean age of diagnosis is 65 years, so age is a risk factor, but it's a risk factor for most cancers, as we know. The only really identifiable risk factors for bladder carcinoma is smoking. In terms of clinical manifestations, mostly asymptomatic, about 20%, asymptomatic. Otherwise, the hallmark clinical manifestation of hematuria is, bladder cancer or bladder carcinoma is hematuria. Anytime there is hematuria, especially in a male, it is assumed to be bladder cancer unless otherwise proven. The third clinical manifestation might be pain. Again, that would be determined by the location and the size or the extent of the tumor. Usually it is flank or abdominal pain. That's it in terms of part 1 of Unit 6, where we focused upon the disorders of the kidney. Please remember to learn the pathophysiology, which is the etiology, the modifiable risk factors, briefly the pathogenesis, but most importantly the clinical manifestations of all the diseases, disorders, and conditions that we covered in this slide, and that are listed in the learning outcomes for Unit 6 in the syllabus. Remember that you'll only be assessed upon the diseases, disorders, and conditions that are listed in the syllabus for Unit 6 in terms of the learning outcomes, that is. Please contact me or your instructor if you require any clarification or assistance with the content related to Unit 6 or for any other unit in this particular course. Thanks everyone, have a wonderful day. Our next lesson is going to be part 2, which is the fluid, electrolyte, and acid-base imbalances. See you then. Bye.